بسم الله الرحمن الرحيم. رمضان مبارك شباب، وإن شاء الله هاي بداية فصل جديد عامر بالأمان والتوفيق إن شاء الله لكم جميعا. الفصل هذا الثاني محاضراتنا راح تكون سلسلة عن different problems in pediatric gastrointestinal system. So we are going to start with listing some of the congenital anomalies that may affect the gastrointestinal tract. As you know, the gastrointestinal tract starts from the oral cavity down to the pharynx, esophagus, stomach, small and large bowel, associated also with the liver and the pancreas organs. The esophagus is a muscular tube. In adults, it measures about 25 centimeters in length, and it connects the pharynx to the stomach. It takes a straight course through the mediastinum of the thorax, and it pierces the diaphragm at the esophageal hiatus to enter the abdomen and the stomach. The bolus of food is propelled within the esophagus by peristaltic waves. The esophageal wall is composed of two layers of muscles. One of them is the circular layer, and the circular muscles, when they contract, they constrict the esophageal cavity, and it pushes the bolus downwards towards the stomach. While the longitudinal muscle layer, when it contracts, it leads to shortening of the passageway or of the esophagus in front of the bolus, so that again it enhances the propulsion downward towards the stomach. In addition, there is what is called the gastroesophageal sphincter, which contracts and opens in certain timing in order to allow the bolus of the food to pass down from the esophagus down to the stomach, and when it contracts, it prevents the backward movement of the stomach content into the esophagus. There are some peculiarities affecting the gastrointestinal system of the neonate and the child. We mean by peculiarities some differences from the adult gastrointestinal system, or something that they are specially seen during the neonatal and early childhood period. One of them is that sucking and swallowing are automatic reflexes. Initially, I mean that they are involuntary reflexes early in life. Gradually, they become under voluntary control as the nerves and the muscles develop by the age of 6 weeks. So initially, sucking and swallowing, it is a reflex. It means that is involuntary act. Within 6 weeks, it turns to a voluntary act. Then the other peculiarity is the newborn stomach capacity. At birth, it is just 10 to 20 milliliters, and it expands rapidly to 200 ml by the age of 1 month, and it reaches the adult capacity that is 2 to 3 liters by late adolescence. And minding you, in 10 to 20 milliliter, it means something around tablespoonful, يعني ملعقة الطعام الكبيرة. While the 200 ml is a bit less than a big glass, شوية أقل من المج العادي اللي تشربون به القهوة والنسكافيه. The other peculiarity is the gastric emptying time. Early in life, it is short, 2 to 3 hours in the neonatal period, and it turns to 3 to 6 hours by 1 to 2 months of age. This is why early in life the baby would need more frequent feeding during the day, while the number of the feed or the frequency is reduced later on because the gastric emptying takes longer and the baby may sleep longer, then he may ask for another feed. Other peculiarities is that the stomach lies horizontally in the infancy and neonatal period. It is round until approximately 2 years of age. Lying horizontally, it means that there is a possibility of spillage of the stomach content backward into the esophagus. In a horizontally lying baby, the gastric fundus is low as the antral part of the stomach. A horizontally lying baby, most of the babies, they are lying horizontally in bed or in their mother's lap. فهو الطفل في بداية حياته غالبا هو supine, horizontally lying. في هذا الوضع راح يكون الجاستريك فندس في نفس المستوى of the stomach antrum، بمعنى بداية الستومك ونهايتها في نفس المستوى. لهذا نوصفها أنه هي horizontally lying، ولهذا again this enhances the spillage of the stomach content back into the esophagus. At the same time, there is a the lower esophageal sphincter has got a poor development of the mucous membrane and the muscular layer, so its tone is decreased or relaxed. بمعنى the gastroesophageal sphincter is somewhat lax. On the other hand, the pyloric sphincter is well developed. بمعنى the sphincter في نهاية السtomach is competent, strong, while the sphincter at the beginning of the stomach that separates from the esophagus is somewhat poorly developed and lax. So these both factors are additional in the liability of the stomach content of the newborn to be spilled back into the esophagus. The fundus of the stomach lies under the left dome of the diaphragm. All these factors, it enhances gastroesophageal reflux and regurgitation, which are very frequent phenomena in the newborn infants. Other peculiarities of the gastrointestinal system in the neonate and infants is that the gastric acid secretion is deficient in several digestive enzymes that are usually not sufficient until the age of 4 to 6 months. So gastric enzymes are low, digestive enzymes are low until the age of around 6 months. The stomach pH is 5 compared to the adult, which is 2, which means that less hydrochloric acid, less acidity is present in the baby's stomach, which means lower digestive ability. At the same time, the pancreatic enzyme activities are still low early in the neonatal and infancy period. So the low amylase, which is responsible for initial digestion of carbohydrates, is insufficient, resulting in a sort of intolerance to the starches. If cereals are given before the age of 4 to 6 months of life, the infant may develop gas and diarrhea. لأنه الcereals المajority مالتها هي it contains starch. It needs amylase to be digested. Undigested cereals will end in bloating, that is gaseous distension of the abdomen, and diarrhea. Lactase is an enzyme that breaks down or hydrolyzes lactose, the lactose sugar present in the milk, any type of milk. Lactase levels are low in the preterm infant. It increases gradually during infancy and then declines after early childhood. The low lactase level results in incomplete absorption of the lactose which is in the milk, which can cause again gas, abdominal distension, and diarrhea. So these problems are mainly seen in premature preterm infants. Again, there is a low level of lipase, which is responsible for the digestion and absorption of fat. Fat in the breast milk is absorbed more readily than that in the formula because the human milk contains its own lipase. فالhuman milk هنا يساعد deficient intestinal system of the neonate and infant by providing a readily made lipase present in the maternal milk. There are three types of stool. The infant's first stool is called meconium, which is described as a sticky, greenish black in color. It is composed of the intrauterine debris such as bile pigment, epithelial cells, fatty acids, mucus, some blood, and amniotic fluid. The passage of meconium should occur within the first 24 hours of life. If it is delayed beyond that, we will call it as delayed passage of meconium, that is usually related to certain diseases. So the normal pattern, every baby should be able to pass his initial meconium within his first day of life. The passage of meconium will be followed by the passage of the transitional stool before turning or reaching to the normal stool of the infant. So the transitional stool, it appears usually by the third day after the initiation of feeding. Initially there is meconium for 2 to 3 days. Then on the third day onward it will be followed by the transitional stool, provided that the baby was feeding. If not, if he was not feeding, he will continue passing meconium, that is the sticky greenish black stool، واللي غالبا يشبه اللي احنا نسميه hunger stool. يعني البيشنت سواء whether it's a child or an adult, when he stops eating, when he stops feeding for several days, his stool would turn as dark greenish in color, mucousy, and sometimes even described as black, which is called the hunger stool. This is when the GI system is empty, no feeding. So again, the person, the human being, will start just passing these debris, bile pigment, epithelial cells, some fatty acids, and mucus, and so. So the transitional stool, it appears on the third day after initiation of feeding. It is greenish to brown to yellow in color. It is less sticky than meconium. It may contain some milk curds. أحيانا يشوفون خثر بيضة مال milk واضحة grossly بالstool. The typical milk stool is passed usually by the fourth day of life, again provided the baby is feeding during the passing days. In breastfed infants, the stools are yellow to golden in color، لونها ذهبي، and pasty in consistency، يعني بها بعض الليونة وممكن نشبهها بالطين الاصطناعي اللي يلعبون به الأطفال، with the odor similar to that of sour milk، تشبه الحليب المتخثر أو المحمض. Infants fed on cow milk formula, the stool are pale yellow to light brown، اللون أفتح ومائل إلى البراون. it is firmer in consistency. هناك كانت golden yellow و pasty يعني softer than that of the bottle feeding baby. اللي هنا الcolor yellow to light brown, firm in consistency, and have a more offensive odor. Breastfed infants usually have more stools than do bottle-fed infants, بمعنى they pass more frequent motions. The stool pattern, anyhow, in a newborn baby can vary widely. 6 stools per day may be normal for one infant, whereas a stool every other day may be normal for another. So every newborn, every infant have got his own normal pattern. Some babies, they are already used to pass about 6 motions per day, and yet they are normal, they are not having diarrhea, they are not dehydrated, and they are growing normally. Whereas others, they may pass only a bowel motion every other day, and still they are normal, they are not distressed, they are not showing features of intestinal obstruction. These are the 3 types of stool. A is meconium اللي وصفناه, it is dark green to black in color. B is the typical stool of the breastfed baby, which is golden yellow, and it contains more water than that of the bottle-fed baby. The bottle-fed baby passes firmer stool with a color that is nearly brown. Okay, Shabab. We will continue in our work discussing some of the common congenital anomalies affecting the gastrointestinal tract. One of the most important one that usually presents as emergency early in life is esophageal atresia with or without tracheoesophageal fistula. So the problem is atresia of the esophagus plus minus a fistula connecting the trachea to the esophagus. This is a diagram representing the most common type of this congenital anomaly, where the upper esophagus ends as a blind pouch and the lower end of the esophagus is connected to the trachea. So esophageal atresia, it means there is lack of communication between the proximal and distal esophagus. أكو قطع, أكو disconnection. This type forms around 90% of the defects. It is due to failure of the esophagus to recanalize between the 4th to 6th week of gestation. So this error, this anomaly usually occurs during the first trimester, where the GI tract is a solid tube and it starts recanalizing, but this process stops, leading to this interruption in the lumen of the esophagus. There are 5 types of this congenital anomaly. The most common one, which forms around more than 80% of the conditions, is in the shape of proximal atresia of the esophagus with a distal fistula connecting the lower part of the esophagus to the trachea. This is demonstrated clearly here, where the upper esophagus is a blind pouch and the distal esophagus is connected by a fistula to the bronchial tree. This anomaly forms more than 80% of esophageal atresia conditions. The other next one in frequency, which forms around 8 or 9% of esophageal atresia, is associated with total interruption of the esophagus and no any connection to the bronchial tree. In this situation, there will be no aeration to the stomach and the lower gastrointestinal tract. So when we have a plain X-ray of the abdomen in such newborns, usually we see no gas shadow in the abdomen because the esophagus is totally obstructed, interrupted. The third type in frequency is what we call the H-type fistula, where there is actually no atresia. The esophagus is straight, but there is a side connection, a fistula connecting the esophagus to the bronchial tree. Usually this form presents later in life as recurrent chest infection due to the recurrent aspiration of the food particles. Type 4 and 5, they are very rare, and their clinical presentation depends on the anatomical defect. The diagnosis starts when there will be inability to pass a nasogastric tube to the stomach of the baby. In the plain X-ray, we may see a cold and nasogastric tube, and contrast study are usually not needed in the diagnosis except in the problems of H-type fistula. There are some associated congenital anomalies: esophageal atresia, cardiovascular defects in the shape of VSD, tetralogy of Fallot, coarctation of the aorta, patent ductus arteriosus, etc. And there is what is called the syndrome, the Bacterial syndrome, which occurs in 10% of the conditions of esophageal atresia, which is formed by vertebral defects, anal atresia, tracheoesophageal fistula, and sometimes renal anomalies and skeletal abnormalities. Frequently, they have imperforate anus and sometimes problems in the small intestine in the shape of malrotation. This diagram again demonstrates that this type of anomaly is the most common, and a blind upper esophagus, the lower esophagus connected by a fistula. The next more common is type A, only both parts of the esophagus, they end blindly, total interruption in the esophageal lumen. But this one forms the most life-threatening here because the upper esophagus is directly connected to the trachea, so any attempt to feed the baby will lead to fatal inhaled aspiration of the feed. This form points to the H-type fistula, where the esophagus is patent, not atretic, but connected with a fistula to the trachea. Again, this is a diagrammatic representation, and as you can see, the diagram C is the most frequent one, which forms more than 80% of the lesions, followed by the type A, two blind pouches in the esophagus, totally disconnected from the respiratory system. The incidence of esophageal atresia with or without fistula is considered common, 1 in every 3,000 live births, up to 1 in 4,500. One third of these babies, they are premature, so it is more common in premature born baby. How does it manifest? Starting in utero, usually the mother presents with polyhydramnios. This is because any upper gastrointestinal obstruction in the fetus is usually associated with maternal polyhydramnios. And I mean by upper gastrointestinal obstruction is that any obstruction affecting the upper part of the duodenum upwards. This represents the upper GI tract. So anything affecting the first part of the duodenum upwards, the stomach, the esophagus, all these organs are considered upper gastrointestinal organs. So starting from maternal polyhydramnios, next, the newborn baby, when he is delivered, he will usually develop excessive oral secretions, that is, excessive frothing of saliva spontaneously even before trying to feed him. So usually the baby develops froth around his mouth، وغف يعني يوقف أو يزبد الأهل راح يوصفوا، and usually it occurs after cleaning or after suctioning. When the carer or the nurse attempts to remove this saliva froth, usually it recollects very rapidly. Routinely, in resuscitation of babies, we pass a catheter into the oropharynx and down to the stomach in order to clear the passages from any swallowed debris from the birth canal. So in such babies, usually the catheter cannot reach the stomach because, as we have described, the most common anomaly, it includes a blind upper pouch esophagus. So such findings, a frothy baby, that the froth recurs very rapidly after cleansing, and inability to pass a catheter down to the stomach, it should lead us to the suspicion of this congenital anomaly, and we should avoid feeding such babies in order to avoid inducing aspiration in them, because the blind upper esophageal pouch is a small pouch and it fills rapidly with any feed, whether water, whether sugar solution, whether milk. And after being filled, it will spill spontaneously into the trachea, and the baby will develop choking, cyanosis, and coughing with feeds. So if the carer did not recognize these abnormalities and he tempted to start feeding, the baby would choke بمعنى يغص يشرق بالعامية. So choking, cyanosis, coughing with feed, again this is the last alarm. The carer should take care to stop feeding anymore, and he should seek a medical evaluation. As we have mentioned, that around 30% of such babies, they have associated congenital anomalies in the heart, in the kidneys, in the skeleton, etc. How do we diagnose such conditions? Starting from the history of maternal polyhydramnios, from the resuscitation room where the carer cannot pass a catheter into the stomach of the baby because it stops short in the esophageal pouch, and the carer will feel resistance. We cannot push the catheter downward. The presence of frothing, excessive frothing, and if there has been a chance that the baby was given a feed, he will develop choking and coughing. Later on, we should prove this diagnosis, and the diagnosis is quite easy, which is by having a plain chest x-ray of the baby in the erect position after passing a radio-opaque nasogastric tube. So, on attempting to pass a nasogastric tube, usually it stops short لأنه الأسوفيجيال pouch غالبا اللينث مالتها ما يتجاوز 10 to 12 centimeters. We feel resistance in passing this tube, but sometimes the tube coils يلتف inside the esophageal pouch, and the doctor may feel that as if he is going down to the stomach. So to make sure, we try to pass the nasogastric tube which should be a radio-opaque tube, because otherwise we cannot see it, we cannot visualize it in the X-ray. So passing with these suspicious manifestations, we pass a radio-opaque nasogastric tube as much as we can, and we take a plain chest X-ray film in the erect posture. Usually we can see that the tube have stopped short before reaching the stomach, or it have been even coiled inside the esophageal pouch. In the coming slides, you will see examples of such X-rays. The treatment, anyhow, it's a surgical emergency. The baby should be resuscitated as quickly as possible. Preferably, if we catch him before starting feeding, we prefer to keep him in the prone posture so that he doesn't aspirate his saliva and the debris in the esophageal pouch, with continuous suctioning to remove any debris in the esophageal pouch, then allowing him for surgery. The baby will need correction of his body temperature and rehydration. After clinical stabilization, he should be offered surgical correction as soon as possible, where they cut the fistula connection and they try to connect the blind esophageal pouch with the lower part of the esophagus, or if it is a difficult surgery, he may be offered a gastrostomy to allow for feeding until the general health of the baby allows for connection between the two parts of the esophagus. This is the typical chest X-ray. This is a plain X-ray, PA view, and as you can see, there is a radio-opaque line which is inlining the blind esophageal pouch. يرسملي البلايند esophageal pouch. هذه هي الراديو أوبيك تيوب اللي نحاول احنا ندخله، ومثل ما قلنا احيانا هو يلتوي داخل الاسوفيجيال باوتش، فهسه كونه راديو أوبيك بهذا اللاين اللي هو يعكس الراديشن هو راديو أوبيك، فلهذا واضح صار وقدرنا نشوفه. فهنا هذا التيوب ملتف داخل البلايند esophageal pouch، فلهذا دا أشوف هذه الcoiled effect. This film shows that the tube have stopped short بعد أن يوقف هنا وما دا أقدر أنزله. هذه هنا المفروض تكون الستومك شادو، فهو لو ماكو obstruction المفروض هذا الراديو أوبيك لاين الواضح هنا دا نشوفه المفروض يوصل below the diaphragm. The other common congenital anomaly, by the way, if we do not recognize the early alarm signs pointing to the presence of esophageal atresia, and if we allow feeding, the baby will aspirate the feed, especially if it is milk. It will lead to a sort of milk pneumonia, or what we call lipid pneumonia, which is very disastrous. It carries a high mortality and it destroys the surgical field, so that even if the baby have got the chance to do surgery, the prognosis would be poor because the surgical bed is inflamed, and the inflammation is sort of chemical pneumonitis. It is not easily treated by antibiotics or any medications. So the other congenital anomaly is the diaphragmatic hernia, which means there is herniation of the abdominal contents into the thoracic cavity. The incidence is 1 in 2,000 up to 5,000 live births, so it is a very common anomaly, and it forms around 8% of all major congenital anomalies in general, not only the gastrointestinal anomalies. Where does it occur? More commonly it occurs in the posterolateral segment of the diaphragm, which is caught in the foramen of Bogdalic. Less frequently, it occurs retrosternally in what is called the foramen of Morgagni. How does it manifest? According to the site and according to the severity of the defect. The larger the defect, the more intestinal viscera would herniate into the thoracic cavity, so the earlier and the more severe presentation will be seen. So if the hernial defect is smaller, a smaller part of the abdominal viscera will herniate, leading to milder clinical manifestation and even later presentation in life. So the diaphragmatic hernia may be diagnosed at any age, but the large and severe ones usually they present early. So in the neonatal period, the baby develops severe respiratory distress and cyanosis starting from birth. If it is somewhat delayed, so he may present even with vomiting, discomfort after feeding, abdominal pain, and even features of intestinal obstruction. This is because usually the stomach is lying now in the chest above the diaphragm, so the stomach capacity would be small and the baby will vomit very easily after feed, and definitely he would develop fullness in the stomach that may compress the lungs and it disturbs the breathing of the baby. So he develops distress after feed, abdominal pain because the herniated viscera have got a poor blood supply, and even the baby or the child may develop picture of intestinal obstruction, that is persistent vomiting, possibly bile-stained vomiting, with no bowel motion, that is constipation. Physical findings, they depend on the degree of the displacement. So if the defect is large and a large volume of abdominal viscera herniate into the thoracic cavity, the baby or the child would present with a scaphoid abdomen. scaphoid نقصد خاسفة، بطنة خاسفة لأنه الabdominal viscera زاحفة للthoracic cavity. Respiratory retraction, because he will develop dyspnea due to the compression of the lungs by the herniated abdominal viscera. Sometimes they present with shock, خصوصا with the retrosternal type of hernia. It will compress the heart and affect the cardiac output. On percussion, the chest would be tympanitic because the bowel loops have herniated inside the thoracic cavity, and the bowel loops always contain air inside it. This is why when we percuss the chest, we may feel tympanitic tune on the side of the hernia, and we may be able to hear bowel sounds in the chest by the stethoscope, definitely. With such conditions, usually prenatal diagnosis is possible through ultrasonography, and the defect may be discovered as early as the second trimester. What is seen is a mediastinal shift. The mediastinum is shifted to one side. The examiner may be able to see visceral herniation, stomach, intestines, sometimes liver, kidney, spleen, and gallbladder inside the chest. So abnormal position of certain viscera inside the abdomen. The items in red, they are bad prognosis signs. That is when the liver is herniated into the chest, when there is intrauterine growth retardation, when there is significant polyhydramnios, and sometimes even there is fetal hydrops. And we mean by fetal hydrops is that the baby have got fluid collection in all his serous cavities, pleural effusion, ascites, scrotal edema, and even fluid collection subcutaneously. هذه معنى الفيتال hydrops. So all the red marks هذول it points to a bad prognosis. This is a presentation of prenatal diagnosis where the uterine ultrasound examination here shows that the stomach is lying at the same level of the heart. معناته the stomach is herniated into the thorax. The same here with Doppler examination. This is the heart and this is the stomach cavity. They are lying at the same level. This is a magnetic resonance examination where they have injected a radioic contrast into the amniotic cavity, so the fetus would swallow this amniotic fluid, and here we can see that the stomach, which is filled with radioic material, is lying above the diaphragm. So it means that it is lying inside the thoracic cavity, in addition to some of the bowel loops اللي هي red arrow. Again, this is a magnetic resonance in utero, showing that the contrast is passing into the thoracic cavity. What about the postnatal presentation? As we have mentioned, there will be respiratory distress according to the severity and the size of the hernia. The abdomen may be scaphoid, and the chest would look as if it is barrel-shaped. We mean by barrel-shaped, increased anteroposterior diameter of the chest. Auscultation of the lungs will reveal poor air entry, and we may see that there is shift of the heart or the mediastinum to the opposite side. بمعنى نسمع الهارت sound on the right, because most frequently احنا قلنا الهرنيا تصير للposterolateral foramen of Bukdalik, and most frequently it occurs on the left side. So frequently we find that the heart is shifted to the right, and we may hear bowel sounds in the chest at the side of the hernia, and if we percuss the area, it will be tympanic. So this X-ray also is useful, and every time when we face babies whom they are dyspneic, it is preferable to pass a radioic nasogastric tube before having a plain X-ray of the chest and abdomen. So in this X-ray, typically we see that on the left side, اللي هو herniated side, we don't see a diaphragmatic dome. It is there on the right side, but on the left ماكو لاين يمثل لي diaphragmatic dome. And what we see, multiple air fluid levels in the left side of the chest. المultiple air fluid levels ممكن تكون intestinal loops واللي هي دائما تحتوي air و fluid, ف it may occupy the thoracic space. بس هذه ممكن تشبه لي مثلا multiple abscesses. أحيانا أكو entity نسميها cystic adenomatoid transformation congenitally, يعني multiple cysts congenitally in the lung. To prove that this is a diaphragmatic hernia, passage of the radioic tube, it helped us لأنه نزل وصل للستومك ورد صعد above the diaphragm, فمعناته الستومك plus minus the duodenum, they are both lying above the diaphragm. هذا الدايجرام دا يمثل لي الوضعية مال الإكس راي هذه اللي هي هنا عندي قطع بالdiaphragmatic dome وفي مكانها some of the stomach, some of the bowel loops have herniated above into the thoracic cavity. So this is the typical diagram. هنا عندي abdominal viscera passing beyond the phrenic dome وعابرة هنا عندي spleen عندي part of the stomach عندي intestinal loops. The lung here is compressed by the pressure of the abdominal viscera, and the mediastinum is pushed to the opposite side, again compressing the lung on the opposite side. And sometimes such babies are born with pulmonary hypoplasia, which is again a very poor prognostic factor for the response to the surgery. This is what we mean by a scaphoid abdomen. that تشوفون هنا الابdomen is sunken خاسفة, while there is increased AP diameter in the chest اللي نسميه barrel chest. Same. So how do we treat such babies? إذا احنا من الهيستوري شفنا early dyspnea early in life, شفنا intolerance to the feed, the baby develops dyspnea and vomiting after feeding. شفنا physical findings, the scaphoid abdomen, barrel shaped chest, and auscultatory finding اللي حكيناها. So the diagnosis is by having a plain chest x-ray again after passing a radio-opaque nasogastric tube and looking for the findings that have been already described. How do we manage them? We need to raise the head and the chest to reduce the pressure of the abdominal viscera on the lungs and apply continuous nasogastric suction to suck as much as possible from the fluid and air present in the stomach and intestinal loops to reduce the pressure on the lungs. With early presentations, especially as we have mentioned, there is a possibility of pulmonary hypoplasia, يعني poor development of the lungs. So babies may need mechanical ventilation. Due to the severe dyspnea, usually they suffer from severe acidosis, which is both respiratory and metabolic acidosis due to the severe hypoxia. Sometimes we need to treat for pulmonary hypertension, especially when there is pulmonary hypoplasia with poor development of the pulmonary vascular bed. So we need to take care of these conditions. Sometimes we need ECMO, extracorporeal membrane oxygenation, to improve the pulmonary function prior to exposing the baby to the radical treatment, which is surgery. So fatalities in early presentations are usually high. This is because usually there is severe compression of the lungs with all the listed complications. هذول عندهم severe acidosis, عندهم pulmonary hypertension. They need either ECMO or mechanical ventilation and stabilization of their condition before allowing for surgery. Survivors from surgery may continue to have abnormal pulmonary function tests all of their life. Okay, Shabab, we are left with the congenital anomaly of hiatal hernia. Again, there will be here herniation of the abdominal viscera into the thoracic cavity, but it is through the esophageal hiatus rather than through the domes of the diaphragm. So the frequent type is named as the sliding type, more than 90% of the conditions, which is composed of a shortened esophagus for a reason or another, leading to dragging of part of the stomach into the thoracic cavity. So the stomach is continuous with the esophagus. This is the sliding hiatal hernia. The other type is called the paraesophageal hernia, which is less frequent, where part of the stomach fundus herniates alongside the esophagus into the thorax. This type of herniation is vulnerable to serious strangulation. This part of the stomach fundus will be incarcerated through the esophageal hiatus, leading to impairment of the blood supply of this area and strangulation. So it will be prone to ulceration, bleeding, and dysphagia. The problem here with the sliding type is that we have lost the effect of the gastroesophageal angle, which is called the angle of His, which prevents the reflux. So the whole presentation here would be just a gastroesophageal reflux, and clinically we cannot differentiate between the two conditions unless we perform imaging studies. So we will deal with this problem together with gastroesophageal reflux. We have mentioned previously that reflux disease is very common in neonates and in infants due to the anatomical differences in their esophagus and stomach early in life. So regurgitation and spitting is very common in neonates. So let us revise some of the definitions. What do we mean by gastroesophageal reflux? It is the passage of the gastric contents into the esophagus. What do we mean by GERD, gastroesophageal reflux disease? It is when the gastric contents reflux into the esophagus or oropharynx and produces symptoms. So just the reflux without a symptom, it is only reflux disease. While when it leads to symptoms, it is gastroesophageal reflux disease. What do we mean by regurgitation? It is the passage of the refluxed gastric content into the oropharynx. Vomiting is expulsion of the reflux gastric contents from the mouth. So sometimes you see that the baby as if he is re-swallowing the stomach content because the reflux or the regurgitated material, it passes from the stomach only to the pharynx or to the mouth, and the baby may swallow it back once more. While when it is expelled outside, it is called vomiting. What's the difference between reflux and reflux disease in infants and children? Reflux alone, there will be regurgitation with normal weight gain. يعني هنا نسميهم spitter babies. Frequently the baby may spit, ممكن يرجع some of his milk feed, and usually the vomiting here is non-projectile, and he brings back the same milk content of his feed, not associated with bile, not associated with blood, etc. So the baby continuing thriving well and gaining weight because this is a benign phenomena. While when there is reflux disease, there will be usually poor weight gain. In the usual regurgitation or the reflux condition, there are no signs or symptoms of esophagitis. While in reflux disease, what are the signs of esophagitis is irritability in the baby. In the older child, he may complain of pain in his lower chest, dysphagia, inability to swallow, hematemesis, and iron deficiency anemia due to the persistent ulceration of the esophagus by the stomach acid and persistent loss of blood. In the normal physiological regurgitation, there are no respiratory symptoms, while in reflux disease, sometimes the baby develops apnea and cyanosis due to the sudden aspiration and spilling of the droplets of the milk into the bronchial tree. They may present with recurrent wheezing, simulating asthma, due to recurrent aspiration, and sometimes even as recurrent pneumonia with chronic cough, and sometimes stridor due to the irritation of the vocal cords. In the physiological regurgitation, there are no neurobehavioral symptoms, while in reflux disease in neonates and infants, they may develop what is called the tilting of the neck, which is named as the Sandifer syndrome. Here, usually the baby tries to tilt his neck and backwards in an attempt to stretch the esophagus, to lengthen the esophagus, so that attempting to reduce back the irritating acid stomach contents that have reached the esophagus, to push it back into the stomach. So, what is the prevalence of regurgitation or reflux in infancy? It is very, very common actually, and the peak is seen around 4 to 6 months of life, reaching to about 70% of infants, of normal infants. They may have physiological regurgitation. And sometimes this reflux starts from the early days of life, من الأسبوع الأول. And the peak usually is seen around 4 to 6 months of life. Usually it ameliorates spontaneously thereafter, والسبب غالبا يعزى إنه after 6 months the baby starts to sit up, so raising his back, طلع من الهوريزونتال supine posture اللي هو دائما كان بيه بالأشهر الأولى من حياته. Assuming the sitting posture and solidifying his feeds, هنا بدأ ياخذ solid food, the solids are less likely to be regurgitated than the liquid milk formulas in general. So both these factors, they work together to reduce the symptoms and the prevalence of regurgitation after 6 months of age, reaching to the end of the first year of life. Usually very small percentage continue to suffer from reflux. So the classical presentations is vomiting, sometimes pain, which is early in life is shown as irritability because the baby is unable to describe his pain, so he cries a lot. And sometimes in pathological reflux disease, there will be failure to thrive, that is, failure to gain weight. Hiccup, yawning, and sneezing are very common in such babies. Hiccup اللي هي نقول الشهيقة, yawning يتمصر يتثاوب, and sneezing are common manifestations. Severe symptoms may occur in the shape of pulmonary compromise, apnea, pneumonia, recurrent wheeze, asthma, recurrent stridor. All of these complications occur due to a recurrent aspiration of drops of the stomach content down into the bronchial tree. There may be gastric bleeding, anemia, hematemesis, bloody vomitus, continuous iron deficiency anemia, unresponding to tonics due to the continuous loss of blood through the GI system. Esophagitis, which is seen as irritability and pain in the patient, plus minus blood-stained vomitus. And what we have described, the Sandifer syndrome, you will see the pictures soon, inshallah. Sometimes there is a silent reflux, which is asymptomatic. So this is what we mean by the Sandifer syndrome. The baby tilts his head backwards and to one side in an attempt to stretch the esophagus to allow it to accommodate for more larger volume of the regurgitated stomach contents and trying to push them downwards back. This is again an example of the Sandifer syndrome, arching of the back and backward movement of the head of the baby in an attempt to stretch the length of the esophagus. And sometimes this condition may be misinterpreted as a seizure event, a convulsion. It is not convulsion, it is just voluntary stretching of the back of the baby in order to stretch his esophagus. The diagnosis is done by history, vomiting of the same milk content. Usually it starts soon after birth, within the first few days of life. It does not contain bile, but with the progression it may contain some blood sometimes. Upper GI series, we mean contrast barium study of barium meal, and endoscopy may be helpful to demonstrate the lesion of the esophagitis affecting the refluxing esophagus, and the barium contrast study is helpful to demonstrate if there is an associated hiatal hernia which is exaggerating the reflux condition. pH probe, that is continuous measurements of the pH in the lower esophagus, is sometimes helpful to document the presence of acid reflux in the patient. And sometimes we need testing for milk allergy because especially babies whom they are fed on formula, due to sensitization to the milk protein, they may develop exaggeration of the reflux into the reflux disease state. So treatment depends on the severity. In mild conditions, no treatment is required, and the condition usually resolves by 12 to 18 months of life. So all what we need is to assure the mother that the condition is self-limiting, try to correct the position in which the baby sleeps in bed by attempting to raise the head and the back of the baby. Sometimes in bottle-fed babies, we shift them to a thickened formula, which is a milk formula that have been thickened by the addition usually of starch, because you cannot increase the amount of milk powder in the milk feed. So instead they thicken it by adding some starch, because a more solid, a thicker feed, usually it stays better in the stomach and it is not regurgitated easily. So after feeding, we need to put the baby on his stomach, prone, and elevate the head. We usually advise the mother to give small, frequent feeds rather than large feeds to avoid over-distension of the stomach, and sometimes we use thickening of the formula. In severe conditions, a refluxing baby, especially if there is an element of hiatal hernia associated with it, usually they may require surgical intervention.